Hello and welcome to MEPcast, a podcast for maternity education program of Clinical Skills Development Service. In each episode, we explore ideas and issues on how we can enhance and improve the delivery of maternity care education.
Hello and welcome to Queensland Health Clinical Skills Development Service Maternity Education Programme podcast, MEPcast. My name is Sue Hampton. I'm your host today. I am the midwifery educator here at CSDS and I am a registered nurse and midwife with over 40 years of experience in healthcare. We've developed this series of podcasts in relation to clinical situations and clinical experiences aimed at healthcare providers in the maternity setting. Today I'm going to be discussing how to keep labour and birth normal, and I've got a great colleague with me today, Angela Swift, who I've worked with over the last few years and working at the Royal Brisbane and Women's Hospital. Thanks for joining us today, Angie. It's great.
A pleasure to be here, Sue.
Would you mind just introducing yourself really to the listeners? A little bit about your previous experience would be great.
Well, I trained in the UK. I was one of the first students in the direct entry programme there in 1992. So I've been qualified now for 25 years. I've worked in all aspects of maternity care in the hospital setting, but in the last 7 years, really, I've concentrated my career around continuity models. So I was part of the development and rollout of the Ngarrama Midwifery Group Practice here at the Royal Brisbane and Women's Hospital, which is for Indigenous families. I then went to Far North Queensland and developed a midwifery group practice that was outside of the hospital setting. So it was in a country hospital, but women transferred to Cairns to birth. Then I've had a little stint on Thursday Island in midwifery group practice up there, and then I've come back to work in the birth centre here at the RBWH, and I've been here a couple of years now.
Well, it's great to have you back, I have to say. We did miss you while you were gone. So.
Thank you. Missed you guys too.
Great. So over the past few years, there's been noticeably an increase in intervention during pregnancy, labour and birth for lots of reasons. I think our acuity is rising with our women. And obviously the results of new evidence have showed that we've got increased induction rates happening because of what we're doing. What I've experienced is the reduced number of normal presentations and pregnancies and births. And in fact, we celebrate the normal labours now, which I feel quite sad about. How can midwives maintain some normality for the consumers of our care even with some of these high-risk births for their pregnancies and their labours?
I strongly feel that women should always be at the centre of the decision-making about their care, and ensuring women that understand their rights as a consumer, that they're aware of what they should be expecting in relation to involvement in decision-making is really, really important, I think. And a lot of women, I feel, just go along with whatever whatever they're recommended to do without really being truly informed about the risks and the benefits. So it's very easy, when we're in a medical model, for women to be recommended induction of labour for all sorts of reasons and them just go along with it rather than looking at the pros and cons of waiting, whether there's some alternative to going for an induction, for example, or they very rarely ask the question, well, what if we do nothing and we just wait and see what happens? Are there options for additional monitoring and stuff like that to ensure the well-being of the mother and baby rather than just go for that induction at 38, 39 weeks?
So in your practice, how do you manage to weave that in, giving women good advice around that? Because I think that's where we maybe don't do such a good job in the antenatal period. So how do you manage to do that?
Well, look, when women enter a continuity model, they have a primary carer, and certainly in the birth centre and definitely in my team, from the outset, before we even book them in and take them on, we have a conversation about what the expectation is. We don't direct women to education classes or anything like that. We encourage them to read around what they want for their birth. If they want a natural birth, read around that subject and come back to us with what they want to do, whether that's hypnobirthing, calm birthing, whether they're into meditation, yoga, all these things that will enable them to be in control of their bodies, what's happening to them, grow their confidence as mothers and believe in themselves to be able to birth their babies. I think that's like a huge thing for women to believe in themselves, you know, that they are able to do this without intervention and without having to do anything other than just be women.
The interesting thing is you've mentioned your continuity of care model, and you obviously work in the birth centre, which is a low risk model. How do you think we can give all women access to continuity of care, even when they're in that high risk situation? Because often they're the women I think we kind of miss out the good continuity.
Yeah, well, I mean, I've worked in all risk MGPs with very high risk cases, and just having that one person that they can go to makes a huge difference. Even when there's like involvement of multiple other specialties in their care, having that one person that can coordinate it all, bring it all together, explain things to them, take time out to have discussions with them about what their wants are and then their particular needs are, I think goes a real long way in building their confidence and making them feel that they're in control and they've got some say over what is happening to them. I would really love to see more midwifery group practices that are specialists. So specialising, say, for example, in women who have drug and alcohol problems, maybe like social issues, certainly for women who have language difficulties. You know, if we had just a little group of midwives that had a real good relationship with all the interpreters and, you know, could just set up all of their whole care through that one interpreter with one midwife, I think would make a huge difference to outcomes. These are the groups of women that have the poorest outcomes, you know, for themselves and also for their babies. We absolutely know that having a continuity with or a small team of midwives or one midwife will reduce the risk of stillbirth by about 14%. You know, they're less likely to go to the neonatal unit, they're less likely to need an epidural, more likely to have a spontaneous vaginal birth. All of these things we're seeing become less and less in the mainstream, in, you know, standard care models, have about a 10% caesarean section rate in the birth centre. And I know that's the low risk women, but we have an awful lot of first time mothers and it's still that low.
You mentioned the Ngarrama MGP that you worked in, and I think that gives you some comparisons really, which you had some high risk cases in that group, didn't you?
We absolutely did.
So thinking back, and I know it's a few years since you did that, can you remember some of the differences you made to the outcomes for those women?
Well, yeah, I mean, we won some awards with the Round Table for that model of care for Ngarrama, and just within the 2 years that I worked there, we found that the outcomes for mums and babies were on par, if not better, than for mainstream care for that group of women that was, you know, were previously having the poorer outcomes and more likely to have premature births and special care. 2 years in, we weren't seeing that at all. We were doing really well.
So did you find with that model that those women tend to engage better with the healthcare professionals? Because I think that's something that's often an issue, isn't there, in those Ngarrama situations, is that women actually don't engage or families don't engage. So did you find that that was one of the benefits?
Yeah, I mean, the women that chose to come to Ngarrama, and it was open to all Indigenous families, whether it was the father, the mother who identified it, didn't matter, they were able to access it. And yeah, we found that the attendance was much better. You know, all of the women had 5 or more antenatal appointments that they attended. They were confident, you know, to come in because they know there'd be somebody there that knew them, that they cared about them. They didn't have to keep repeating their stories or going over past traumas or incidences that they might have done had they been in, you know, the standard care model. So I think they just had greater confidence that they were going to be cared for in a culturally appropriate way. And of course, you know, we work with the health workers and liaison officers and stuff at the hospital as well. So now I think there's more midwives working in the team that identify as Aboriginal or Torres Strait Islander themselves, which is ultimately what the aim was, that it would become, you know, a very culturally appropriate place. Indigenous midwives in there as well.
That's a great job. And I think there's a lot of other units around, certainly Metro North, that now provide that care, which is fantastic, and we need to build that even more. And certainly your experience in Far North Queensland probably exposed you to even more of that Indigenous healthcare, which has lots and lots of issues, which you have to understand to be able to work in it. So having people who are in that culture helps them to be part of that as well.
Yeah, and I think, on Thursday Island and also in Mosman where I worked, once they knew that the community was aware that, you're a trustworthy service and, word got out that you were okay, actually, you weren't, they would come. I would have women coming at 5 and 6 weeks pregnant to book in, and they wouldn't have done that with their previous pregnancies. And that, in the long-term in pregnancy, it makes a big impact into the outcomes for the babies. Again, I was there about 3 years, but certainly by the end of that 3rd year, we were not getting premature births before 34 weeks, and they would have, several a year prior to that. Yeah, the outcomes.
That's amazing.
Are really,
something
really
to be
good.
really proud of.
Yeah, yeah.
I wanted to ask you a bit about assisting consumers and supporting consumers with difficult situations when they've got to make choices. Because I think in pregnancies, but particularly for women who are not in those continuity models or don't have great support, we do barrage them with lots of information, particularly towards the end of pregnancy, particularly around induction or even cesarean section. Have you got an example you can give me about how you've supported somebody making choices that is difficult?
Yeah, look, I do.
How did you do it?
Yes. Right, so I have one particularly that's always stuck in my mind, and it was kind of a bit of a game changer for me as well, because we always, I think as midwives, we always think getting that normal birth, that's the pinnacle. Getting the vaginal birth, pinnacle of success for us. But this is a slightly different story. But when I was working in all risk MGP, I had a woman come to me, and she was really still distressed. 3 years on since her last baby, she was a cesarean section, and she'd spent the last 3 years beating herself up basically about whether she'd made the right decision. Should she have given in to the doctor's advice to have that Caesar when she did, and all, lots and lots of questions. She was in a continuity model back then, but she went 2 weeks overdue, was then induced, which took time. She got to 3 centimetres, and she was so tired, so exhausted. She said her midwife had run out of hours. There was no one that she knew to look after her. The doctor came in and said, we could just go for a Caesar, and she went for one. And she'd always wondered whether it was the wrong decision, and could she have had that vaginal birth, the natural birth that she really, really wanted. So second time around, we had a good look at the notes and everything to see, what was the problem, was there a cause? Was it, okay to go for a vaginal birth after a Caesar? And yeah, there was no reason why she couldn't. Got it, consent and everything with the consultant. And we made a plan to avoid her going overdue. From 38 weeks, we were going to do twice weekly membrane sweeping to hopefully, so that she would labour, because obviously she wasn't going to be a suitable candidate for induction this time around. She was really happy with that. So that's what we did. And then I think she got to about term +5, ruptured membranes, came in, clear lycra, it was all good, started contracting. I got called in the morning to come in and take over her care, and she was contracting really well. She got to fully dilated. No pain relief. She was ecstatic. She starts pushing, and she's pushing for an hour, half an hour to an hour, and this head's not really coming any closer. A fair bit of cap-up is happening. We have a bit of a chat with the consultant and decide that with her, to have an epidural so that she could have longer. We could just wait. We could wait for a bit of descent, just see what happens. She could continue to be pushing, but rather than be exhausted, she'd be able to concentrate on the pushing. So I think we waited an hour, started pushing again, had another hour of pushing. This baby still really didn't come down. We're just getting more and more caput, and it was a persistent OP. And this is what happened with the first baby as well. So after, it was about 4 hours, the baby was always good. Obviously, we were continuously monitoring at that point. The heart rate was fine, light was clear, everything's good, but this baby's just not coming despite excellent effort on her part. So, the consultant that came in again and we had another chat about it. And, really there was no way to go now. We really needed to go for a cesarean section. The head was still too high to do a vacuum or a forceps. And she was happy. She was like, okay, yeah, we're just going to have to do it. We've done everything. Her partner was still like, could we have a little bit longer? But she's like, no, I think we're done now. We'll just go. Anyway, she was awake, compos mentis and everything. They were all in there for the cesarean section. Of course, the baby comes out with a massive cone head. But it was fine and her recovery was good. And when we debriefed afterwards, she said she was just so happy with the experience because she'd made all of those decisions herself. She was confident that it was the right decision at the time. And as far as she was concerned, she'd done everything she'd wanted. She'd laboured naturally. She'd done all the pushing, everything that you do in a normal birth. The only difference was that it had to come out of the abdomen. And it didn't come out of the vagina. And that was the difference. But she just found it so healing. And it then reassured her as well that the cesarean section she had the first time, she could have done all of that and it would have still ended up the same way. So that's one of those.
I think that's a really great story to share because I think so often as midwives we do get very caught up in the normal birth. It's all got to be normal. But as we know, not all babies come out normally. The most important thing is you have a healthy outcome, which is where I think we get a little bit sidetracked sometimes. So she actually feels like she got a very healthy outcome both emotionally and physically because she actually was the decision maker. And I do believe, and I think you'll agree with me, that this is sometimes where we go a little bit wrong with the decision making taken out people's hands. And labour is not the time to be making decisions, which goes back to that whole continuity of care models. And it's great for that, but we don't have that in every situation. We use the word advocate a lot, and I do think that word is a great word, but I find that some of my junior colleagues sometimes don't really understand what they need to do to be a good consumer advocate. So could you enlighten them a little bit, or what's you in your experiences?
Yeah, well, look, it's not always easy. We're in a patriarchal kind of system. And when you're young and new and maybe don't have the experience or the confidence to sort of stand up for your consumers, it can be quite a intimidating situation. But I think, what I would say is that you listen to the woman, listen and know what they want and, what she and her family want, and be confident to just repeat their wishes, So, well, thank you for that. Thank you for that advice. We'll take a little bit of time here to discuss, and we'll get back to you with our decision, rather than being sort of put on the spot or being encouraged, really, I suppose, to sort of stick with the medical decision. It's not always a medical decision. Sometimes it's a midwifery decision from senior midwives, say we should be doing this now and I recommend we do this. But if you know what your woman actually wants, you can just sort of like take a minute, say, thank you for that. We'll just have a chat about it, get back to you with our decision, and then repeat what the woman wants on her behalf. I guess I have an awful lot of consumers that are quite happy to speak for themselves. But, in sort of the mainstream, that's not always the case because they've not had the antenatal experience of, building the confidence and being informed and having all of the education so that they're pre-prepared to consider information and ask the questions. But I always, encourage women and midwives actually to always ask the doctor or the midwife to say, well, okay, thanks for that, but what are the alternatives? What if we don't do anything and we just wait? And, can you sort of clarify the risks for us? What is that? Can you quantify that in some way? I'm trying to sort of think off the top of my head an example. Say like for a large gestational age baby. Yeah, they've been for an ultrasound scan, usually an ad hoc one because they've had a bit of reduced movements or something. And it comes back, baby's got a large abdomen. And we have, there's certain clinicians that would say recommend induction at 39 weeks, by 39 weeks, because this is going to be a big baby and you could have a shoulder dystocia. Most women will hear that and think, oh, I've got a huge baby on board and I could have a shoulder dystocia, so yes, I'll have an induction, without actually really understanding that ultrasound scans can be highly inaccurate, that the chances of shoulder dystocia are actually quite small, even with a large baby. the fact that we're all actually really highly trained to manage a shoulder dystocia should it occur. And they don't ask those questions like, what are the actual, truly what are the risks? And, that's the kind of situations that women are put in every day. And I think is one of the reasons that we've got, increasingly high induction rates. And so what I often do is, because the women have invested a lot of time and energy and often money into preparing for a natural birth, and they don't want an induction, I sometimes tell them to just go and have a read of evidence-based birth. They do some real good, balanced, research-based consumer information on that website, and they go away and they have a read and they come back and go, yeah, but the risk is small and it's just, shoulder dystocia. So they might not go in the bath for that reason, but there's no reason why they just can't wait for things to happen naturally and still birth in the environment that they want to be in.
I think that's a great answer, and certainly the way you pose those questions. And I think it's the asking, why are we doing this? And I think for the midwives listening, if you're ever asked to do something, the thing I always teach juniors is ask the question why. If you can't answer that yourself, then you need to go and develop that conversation with whoever's asked you that question as to why you're actually doing something. I think an example for me, and you'll smile at this, is, the women coming into the main system, it is examine them, do their observations, do a monitoring and next stage. And I can remember when I was first working here, I was asked why I hadn't examined somebody. Well, I hadn't actually really assessed her properly because I needed to spend time with her and assess her contractions. So I think there is that. It is sometimes they got caught up in that process that we end up in the main system. And if nothing else, I think we can encourage our juniors to just step back sometimes and think, why am I doing this? It's a really good question, but that was a great answer, because you talked a little bit about fear and what that does to people. What's been your experience of when people are very fearful about coming into labour? What do you find happens with those women?
Well, labours sort of wane, don't they? When somebody's afraid, what happens is the adrenaline takes over and it subdues the oxytocin, that is the hormone that they need to feel safe and confident, and helps contractions. So you very often, even in the birth centre, sometimes when, women are so excited and they've had a bit of a scary journey in the car on the way in, when they get to the birth centre, those contractions that have been, 3 and 10 for the last hour and a half sort of fizzle a little bit. But it's about letting women be, I think. I like you said, the process, but women are actually processed in the main system. You're quite right. They come in, these things happen to them: vaginal examination, observations, transferred, sent home, given analgesia. That is not conducive with having a successful labour, really. It's not. Women need to be in a calm, quiet, dimly lit space, surrounded by people that care for her. And so you need to feel loved. That's what gets oxytocin going. So very often when women come into the birth centre, they're usually in good labour. And if it's sort of fizzled out a little bit, I will just leave them alone in there. I'll do a set of observations, we'll palp the contractions, have a little listen in. And then I'll just say, just set yourself up, have a rest, have a drink, have a cup of tea, have a shower, whatever you want, settle yourself in. And then I'll go back. And then usually within an hour, things have started to heat up again because they've settled down, the oxytocin's back up, the adrenaline has settled. And you can see this happening.
Obviously, your birth centres are very much like a home-from-home environment, so it does have a great feel about it. How can we kind of improve our environment in a main system where we've got to be able to deal with high-risk women as well as low-risk women? How would you prep if you were taking somebody, say, into a birthing room that's not a birth centre style to get it to be less confronting for them and for their families?
Yeah, well, I guess just all the same things that we do, I do in the birth centre. So I tell women to bring in things that are going to make them feel comfortable. So whether that's like a pillow from home, whatever they want to wear. I have women that have their birthing dress that they come in and they bring it for all their labours. They wear the birthing dress, or it might be a sarong or something that they feel comfy in. To bring like aromatherapy oils that they like. We've got diffusers and things, so we can make the room smell familiar. And again, sometimes if they don't need the bed, so if they're not on epidural and they want an active birth, push the bed out of the way. and bring out the mat into the middle of the floor and the bean bag and the ball. All of these things are available in the main birthing suite as well as in the birth centre. Utilise the shower. Water is an incredible pain reliever. It works extremely well. Dim the lights. Get some gentle music going. All of these sorts of things that are just going to help the natural oxytocin to bubble up and get things going. Yeah.
We touched on that lady who comes in and doesn't get going, and you've explained that you leave people for an hour. I mean, I've had the ladies who are 2 or 3 hours and you're still going, oh, shall I send her home again? Yeah. What sort of things, other strategies can you put in place to try and re-establish labour if things, say after a couple of hours, she's really not contracting and you're thinking, this lady's overdue, I need to really sort of get things going in. What sort of things have you done in the past? What do you think helps?
Well, so we use some aromatherapy oils, clary sage, like a massage with, some clary sage can work wonders. Nipple stimulation is absolutely proven to work, Sometimes, even get the breast pump out sometimes, but just rolling the nipples works wonders for getting contractions going. We can do some pressure points as well, that can help. There's spots on the feet, like the little toes and the back of the heel, that can help with uterine contractions too. And I've used things, pressure points to avoid putting syntocinon up in the second stage, and it works. It does definitely work. So those sorts of things, you can implement as well. Just getting people moving, going for a walk, those sorts of things can also sort of get things to heat up without having to go straight to the drug cupboard and get the oxytocics out. You can try other things first.
I think something that always sits with me, and I learnt this many, many years ago, is the primary gravid who's been in labour for probably, overnight, hasn't really eaten since the night before they arrive, 3, 4 o'clock in the morning, they've been contracting. Really important about testing their urine, because if they're dehydrated, that often is part of what the problem is. So do you agree with me that trying to get them to making sure they're not ketotic, and then getting them to have little sips of fluid, and even something to eat, because we don't run a marathon without energy, and we are about to run a marathon, probably backwards actually, for your first labour and birth. So that whole simple strategies, I think we've kind of forgotten how to do that, I think, in a way. I've often seen colleagues sending women on the stairs, which I think is another good one, is sending them for a walk around, stomping, doing the squatting positions. I know that one of our colleagues who's now retired used to do a lot of that, and it does work. If it means we're going to prevent intervention, it's a good philosophy.
Yeah, so I sometimes actually, I absolutely agree. They are running on empty sometimes if they've been, in early labour all night or for 24 hours beforehand. So I often send them down the stairs to level 1 to get something to eat, and I get them to crab walk all the way down, because that can help rotate the head and stuff as well into a more optimal position for birthing. So
can you just explain to the listeners what you mean by a crab walk? Because they're probably all imagining.
Yeah, so hold the banister and sideways walk, down the stairs. Bluey. We do the crab walk. Yeah, so I get them to do that, and that can be quite helpful as well. Particularly, I find it really helpful with multis. They can sometimes go off the boil, and just doing that.
That's a lot of stairs down to level 1.
It is a lot of stairs.
So they do have to come up the stairs?
No, they can use the lift to come back up. But definitely I send them down the stairs.
Excellent. I'm sure you've had the experience of the client who does really well, labours beautifully. You've explained you won the lady who had the cesarean section, but has slow progress. And again, we have a bit of a clock on us at times, and being faced with possible augmentation, possible intervention that they maybe don't want. You've talked about some strategies. What sort of things have you implemented in those labours where women are actually probably, 6 centimetres and are getting slow progress? What sort of things have you done to try and expedite? You've talked about pressure points and things. Anything else you can explain or give examples of?
Well, I mean, I guess, if we have somebody that's labour has stalled, we go, you go back to your clary sage and your massage and all the rest of it. Then we can do rupture membranes, do a good membrane sweep and see how that works. Sometimes, it's because the baby's not perhaps in the most optimal position. So I've been learning some like spinning babies techniques and things like shaking the apple tree. So you're just sort of shaking their legs during a contraction, and the head can often if it's a bit asynclitic, can sort of settle into a more optimal position that way. I've learned to do a bit of rebozo as well, and I've found that works pretty well.
Can you just explain that to the listeners? So some people may not know what you're talking about.
Yeah, so rebozo is actually a Mexican, very old technique that midwives in Mexico use, and it's a very long shawl, but you can use it in different positions, and you're really just shifting, difficult when you can't see, but you're sort of just jiggling the abdomen, between contractions, sometimes with contractions, and it helps the baby get into a more optimal position for birthing.
How do the women deal with that when they're contracting? Are they okay with it?
They like it.
They like it.
Yeah,
interesting.
They quite like it. Yeah, and like the head down, bum up position is fantastic. It drops the head out of the pelvis so that when they come up again, hopefully it will have settled into a better position as well. So that kind of thing we do a lot. Certainly I use a lot more of those techniques now. I think working the last couple of years in the birth centre, because it's so focused on supporting women to achieve a natural birth, I've learned a huge amount. So, I've been a midwife a very long time, but you never ever stop learning. And I've applied so many different techniques. And now when I have a woman that does need to go to the birth suite, we still employ all of those techniques. And I assure them, we'll still try and make this as natural and an experience as possible, even if you've got a monitor on and you've got a drip going. We can still go in the shower, be upright. You don't have to be laying on the bed and, have an epidural if you don't want one. And I assure them that they can labour with Syntocin on without an epidural.
Absolutely.
They totally can.
I think something you said which really rings true with me is, doing that rupture membranes at the right moment. Teach people that that's your ACE card. You need to keep it up your sleeve, because it's the one thing you can do that can bring back labour if you have stalled. The whole ARM thing, because the woman's dilated, is if she's contracting, why are we doing it? It's back to that question of, why am I actually doing this? Is it actually essential? So I think that's a great one to hold on to. I think often people talk to women about, if you rupture the membranes, it's going to shorten your labour, blah, blah, blah. But we both know that that's not necessarily the case. There are situations where you have to do ruptured membranes, but I think from the normal labour who's low risk, don't do it.
Leave them alone.
Leave it alone.
Back and watch.
Yes. Sit on your hands is the best one. Yeah. And again, I think because a lot of people come into midwifery from a nursing perspective, they very much into that got to be doing all the time. Right. I certainly learnt as a midwife in a midwife-led unit, that's where I learnt to sit on my hands and actually not do anything. And I heard a GP obstetrician actually from Stanthorpe one day teaching some junior doctors here at CSDS, this is a while ago. He said, listen to the midwives, sit in the corner and be quiet. And I thought, awesome, because that's absolutely true. You need to sit and watch, and I don't think we do enough sitting and watching anymore.
We definitely don't. There's, it's... Yeah, like I say, women are processed and they're on the clock the minute that they get in there. I mean, and I find like with second stage as well, I don't do a vaginal examination to confirm it. I just watch the woman, and I let her just do her thing. And, if she's been like involuntarily pushing for 20 minutes, half an hour, and there's like no sign of a baby's head, then, and it's her first baby, then, then maybe I'd be considering doing a vaginal examination so she's not pushing on an undilated cervix. But generally you just watch and you can see that they're fully dilated, you can see that show, the purple line comes up the back, the change in the behaviour, the noises that are coming out. I really get frustrated when I hear midwives telling women to be quiet and hold their breath and, roar your baby out, just do it. That's what we're meant to do. And there's absolutely nothing wrong with that.
And I think I can remember working with a student a couple of years ago, and I actually said to her, we ought to just open our bits and pieces. And she looked at me very strangely because I was watching this lady doing nothing. I was just sitting watching it, and we had a baby. It was her second baby fairly quickly after that. And she said to me, what did you see? Oh, well, I saw that transition from the behaviour. Yeah. But because we do use drugs and we do use epidurals in quite large quantities, midwives are not experiencing that change in our women. So being able to recognise that, and that was a really good example of looking for all those signs. And there is no need to do another internal examination unless you don't have any sign that this baby's coming. So I agree with you. I always say to people, this is very primeval. It's back to the animal kingdom and we are part of that. Yeah. And that's why, if we had choice, we'd probably go in a cave where it's dark dark and it's secure and it's warm. So we need to make our environment like that as well. You talked a little bit about optimum fetal position, and I think OP labours seem to be increasing, whether that's because we're not as fit, we don't get down on the floor and scrub our floors anymore, and we sit in our chairs. What sort of things have you tried to actually improve that position? Because I think that does often cause awful problems for midwives trying to improve that position.
Antenatally, but I have Jo in my team, who is the spinning babies guru. And, I've learned a lot from her experience and education as well. But we tend to give women like exercises to do, lots of head down, bum up sort of stuff, lunges, left side lying release. All of these things have been shown to really encourage that baby to rotate into an anterior position before labour. And in labour, we continue to do those types of things to encourage that baby around. Actually, we don't have very many OP labours from our cohort of women recently, since we've been implementing these exercises antenatally. And I know it's only anecdotal. We haven't done like a study on it, but the women also feel that they're doing something, and it gives them confidence that the stuff's going to happen. If they do this stuff, it'll all be okay. Rather than being told, your baby's posterior, so this is going to be a long, painful, backache type of labour. And you say, right, well, that's okay. Well, just do these things. And it does seem to work.
I've got a question here about what would be some of the best props you would put in a bag if you were actually going to want to keep certain things that you think are the best things you can use.
Right. Well, I always have a clary sage in the bag. So it's great pain relief, as I've said before, but the women feel relaxed. If you've got the lights off in the shower, they're in that water and they're just in that quiet, dark space, comfortable as they can be in labour. And I can't put that in a bag, but definitely I would want it on hand all the time. What else would I have in my bag? I think I would have a TENS machine. I really strongly encourage women, to invest, borrow, beg, not steal, a TENS machine, particularly first-time mums who quite possibly will have, a longer latent phase of labour. It really helps them rest at home and keeps them at home until they're in really good established labour. And, I use them a lot in the UK. Women use them a lot. Not so much here, but they're having a bit of a resurgence. And I think Aldi had a bit of an offer on recently where they were about $40 or something like that. So definitely a TENS machine as well. You don't need to have like a rebozo scarf, but just a sheet, something like that, just little things like that. Something that, for massaging.
I honestly think we could talk forever. So I'm very mindful of the time. So I think what we'll do is, I had a few more questions, but I think what would be really good is to have a second series of this around normal labour and birth, because there's so much we could talk about. But from today's discussion, what would be maybe one or two key take-home messages to our listeners so that they have something that you think is really important as a midwife?
Education. I think educating and empowering your women to be in control and involved in the decisions that are being made around their care, making them feel that they are in control, definitely, and that they're the centre of it. It is not just about having a live baby at the end of pregnancy. It's how we get there that is important, and the women are central and in control of everything that is happening to them, for sure.
That's great.
So I think that's maybe not just one point, but several. Yeah. And I think just trust women to birth their babies. They can do it. We haven't changed that much in the last 10 years that we've suddenly become disabled around childbirth and we can't do it anymore. I think we just, need to trust women, stand back and watch, and you'll see that they're able to give birth without all of the bells and whistles and interventions that seem to be employed in the majority of births these days.
Sounds great. So I think I'll just recap on some of our discussion today, if that's okay. Some of the things we've talked about is maintaining normality when intervention is required. And I think your example around the lady who had the caesarean section was a fantastic one to talk about. How continuity of care models can be, we need to increase those. And it's obviously you're very passionate about that, and so am I. And hopefully in the next few years, we will see more MGPs, which I think is probably the answer for those higher risk women. And how we can support clients making their decisions when there are difficult choices to make. It's not easy, and it's definitely not the best time when somebody's labouring. So that antenatal period is so, so important. How to improve our environment to assist the birth process. You've talked about calm, quiet, music, just even in our bigger birth suite environments, you can make that work. And how to be a good advocate for our clients. We're there to support them. We're there to make sure things are safe. I often say I'm like your guide for the day. I'm not here to tell you what to do, but I'm here to guide you. And how to bring the deviating labour back to a normal track before it's too far off the track that we can't actually do that. And the good props. I think that was really good to say what you put in your bag. It's certainly a challenging environment being a midwife today. I've seen a big change in the time I've been a midwife, but we have to move with the times and we have to work with the skills that we have and the cohorts of women and staff that we have as well. So for our listeners, have you talked about a website earlier? Any good examples of anything you'd think would be good for people to read or anywhere to go that you think would be excellent for them?
So Evidence-Based Birth is a really good website that I really like. There's some really good stuff there that's just written it's very simple language, but it's packed full of the evidence and it's just very unbiased and I like that. Spinning Babies is a great website as well. You can just register interest with them and they'll send you all sorts of, you get a little tips on emails of different things that you can do. Where else do I go? There's just trying to think. Can you think of any, Sue?
There's so many out there. That's all right. Two is fine. And if you think of any more, you can always send them to me and we can actually post them on the website. But I think that's amazing. And I just want to say a big thank you for your time today. And it's been great. Like I said, I think we could have spoken for a lot longer. And certainly I think we will revisit this topic again because it's something we need to build on. And the maternity education program, as we said, is building a podcast with all sorts of things. So if you think of anything or your colleagues, then we'd be very happy to continue with the podcast. So thanks again.
Thanks for having me.
That's really good.